Can
We
you
are live.
close the screen, sir?
Sorry.
Santosh, can you close the screen, please?
Yes, sir.
Yeah. Can we go on live?
Yes, sir. We are live, sir.
Yeah. Dear Association of Southern Urologists, we are doing webinars on regular basis on Wednesday evening at around 6 to 6:30. Today, Dr. TA Kishore from Cochin is talking about the robotic renal recipient surgery. Just 10 years back, lot of arguments were there that this surgery is not correct. It is difficult. It may affect the function of the kidney because of the pneumoperitoneum. But the science has been constantly evolving. I am not very experienced in this field of medicine, but because this is not a bilateral discussion, it is unilateral presentation. I have not involved other members, and I have seen Dr. Kishore sir, Dr. Pranjal Modi, and many other transplant surgeons, after their well-versed robotic surgery, they and they came out initially because, and they are doing regularly surgery. To know about this, because there are certain advantages in this surgery, certain disadvantages. So let us listen from Dr. TA. Before that, I introduce him. He is the full member of South Zone Urology, who has done fellowship in robotic surgery, fellowship in uro-oncology, fellowship in endourology, MC-urology, DNB surgery, DNB urology, MRCS, MS. He is consultant urology at the moment and Aston Medicity, performed more than 2,500 robotic surgeries and a pioneer in robotic transplantation, a registering.
Hello.
Just a second.
Hello.
Close the screen. Yes. Sorry, sir. There is some the
I
connection
understand.
problem. I can easily see you.
Sure.
I can listen to you. You please proceed, sir.
Sure. So I'm sharing my screen. Okay.
Yeah.
So Hanmant, you can hear me, no? The other person?
Yes.
Okay, perfect. Yeah.
Santosh, you please respond.
Yes, sir. Yes, sir. Yes, sir.
Okay, Santosh. Yeah. So thanks, Dr. Chandra Mohan, for the kind introduction. I think you are on a roll. Like, I think you had a pure urology session now, and appreciate your eagerness and enthusiasm for all this academic program. And I also thank the ASU for having me here, for having this for this webinar. and all the council members and the secretary and the president of ASU. So, robotic renal recipient surgery is an upcoming topic, and many urologists are probably venturing into that. And many of the people, I think, in another like couple of years, it's going to be uniformly spread across South India, I believe so. So, whenever we embark on a program like transplant, where there's a lot at stakes, we have sought a lot of concerns, quite a few concerns when we start a new program. So, as far as robotic transplant is concerned, we have there's a potential for injury to peritoneal organs. Then, now if you have a bleeding, how to tackle? So, what are the advantages of robotic transplant? And how do you do post-transplant surgery? And how do you mitigate the effect of pneumoperitoneum on graft function? These are all concerns which prop up in our mind whenever we involve in a minimally invasive surgery. So initially, I will go through my technique. I've developed a specific technique over the years. I've combined techniques from these two pioneers in India, Dr. Modi and Dr. Ahlavat, who started the robotic transplant in 2012-13. I started robotic transplant in 2015. So this is my technique. So I place the port very similar to robotic prostomy, except for the ports are shifted a little bit cranially. And you have 5 ports generally, and sometimes we put another 6 port. So that encompasses 3 robotic ports, 1 camera port, and 1 or 2 assistant ports. So the surgery starts with fashioning a big flap that is very similar to a robotic radical prostatectomy with anterior approach. So the flap reaches from all the way from the left side, just lateral to the umbilical ligament, and it goes as far with the right iliac fossa, because generally we keep the graft in the right iliac fossa, most cases. And so the flap is dropped down, and once you reach the posterior abdominal wall, the camera is flipped to 30 down, and you see the triangle of doom. That is the triangle between the iliac, the vas and the gonadal vessels, and the iliac vessel will be right inside that. So once you reach the posterior abdominal wall, what I do is that I just splay apart the vas and the gonadal vessels and sweep the peritoneum, scaffold it, so that you get space to place the kidney there. It's very similar to our open approach. The only difference is that I make an incision in the peritoneum, while open it's purely extraperitoneal. So this is the area in the right iliac fossa which is divided, and then comes to the preparation of the bed. I do minimal dissection of the lymphatics. I hardly try to not to divide the lymphatics anymore. And then once this is clear, the bed is prepared. It's quite fast, very user-friendly approach. Now the kidney is placed through a gel point, which is in the suprapubic region in the phalanx stele, and then we do the anastomosis. So I do 6-0 Gore-Tex, which is a standard, do an anterior layer, and then commence with posterior layer. So that is the anterior layer, and then it is tied somewhere in the middle and the corner. So once the venous clamps are released, then arteriotomy is done. So I don't use any special instruments. I just use the monopolar scissors and use a punch, which is made by the assistant. And you have different sizes of punch, like 2.8, 4, which is custom made. And then the similar fashion, anterior posterior layer is done, followed by the anterior layer. So here you see the anterior layer is started from the corner. So the advantage of Gore-Tex is that Even though it's a slightly bulkier suture, it's very easy to handle. It does not break. So it's an ideal suture material for the minimally invasive surgery. So the last 3 bites are taken in under vision, and then it is tightened one by one. A thorough flushing is done. So once this is completed, the clamps are released. And if there are any oozers or like vessel bleeders, apply Gospies for a while, and then once it mellows down, then either you can put a suture or you can probably stop. You flick the kidney to the other side. So once the kidney is flipped, you can see with this technique, urine does not extravasate much into the peritoneal cavity. A Doppler can be done, which shows the vascularity. And subsequently, you can do a ureteric anastomosis. I prefer to do ureteric anastomosis in extracorporeally, especially in thin patients. Very obese patients, I still do intracorporeally. Why extracorporeal means this comes directly under the phalangeal incision, so it's quite easy to do. And this is how the flap closure is performed. So it is kind of watertight, I would say, blood and urine does not seep into the peritoneal cavity. So it almost replicates what we see in the open transplant. The kidney is completely extraperitoneal. It is not fixed, and it almost replicates the open transplant. So this is how the closure once the peritoneum is approximated. And you can always look the position of the graft by placing the camera through the gel point. And this is the final scar of the patient. So you have 4 or 5 laparoscopic ports and then the small phalangeal incision to place the kidney inside. So the advantages I've encountered as far as extrapetalus is concerned is that with the post-operative bleeding is very bleeding into the peritoneal cavity is prevented. Even the intraoperative is prevented because most of the clots, they get kind of puddled underneath the flap. The torsion of the graft is avoided. The peritoneum acts as a barrier, so you don't the ice does not come into contact with the bowels. And then if you want to convert, then bowel interference is less. The renal biopsy is very similar to open transplant. There is no difference. If there is any post-operative urine leak, potentially it's limited to the extraperitoneal cavity. And in migration of the bulldog, sometimes bulldogs clamps can get lost in the peritoneal cavity, very difficult to retrieve. In those instances also, this is helpful because bulldog clamps kind of settles down underneath the flap. And with phalangeal incision, the additional advantages are the ice can be placed directly on the kidney. If you want to reinforce the kidney with ice while during the anastomosis, it's quite easily accomplished. So again, if you want to do a conversion, it's quite easy to convert. You just extend the phalangeal incision laterally, and the bowel interference is also less, I mentioned. So I'll go to certain variations that we have done in the past. So this is a transvaginal insertion of the graft. Of late, I have not done much, but initially I have done 3 or 4 cases, mostly done in cadaveric patients, and ideally a post-cystectomy patient or a multiparous patient. And the gel point is placed through that, and the kidney is placed through that, and then anastomosis is performed. So the kidney is placed on the flap and subsequently anastomosis is performed. So this basically obviates the need of an incision. So this is how the final scar will come, just the ports alone. So initially, people used to be very reluctant as far as the multiple vessels are concerned. But in most of the high volume centers, they have done across the breadth of the all the potential vascular anomalies or vascular difficulties, like anastomosis to inferior epigastric artery, dual anastomosis, bend surgery and anastomosis. Everything can be easily accomplished in robotic surgery. So these are some of the examples. This is the double anastomosis. So you can see two arteriotomies. This is resorted when the vessels are far away. Say if you have a lower pole vessel and an upper pole or the main vessels, which are difficult to approximate, then we do the dual anastomosis, and it hardly adds about 8 or 9 minutes to the warm ischemia time. So, and it's quite possible with robotic transplant. So this is the second vessel being anastomosed. It's complete. So this is another case where we have a small upper pole vessel and a main vessel. So you can see the main vessel is completed. And you see this upper pole vessel we have done through a small punch. And in this instance, we have utilized 8-0 Gore-Tex, much more finer suture. Generally, I use 7-0 for the artery. And then the anterior layer and the posterior layer is completed. So even these very tiny vessels can be dealt with robotic surgery. So this is one another difficult combination. Initially, I also used to be a little bit circumspect about taking the right side kidney. Here we have a right donor nephrectomy that we are performing. And you can see there is an early branching of the renal vessel. So we are dissecting the interaortocaval region to get the single stem. And you can see the left renal vein on here. And at the interaortocaval, this is artery is clipped. And using endo-TA stapler, which is not available nowadays, we get a fair amount of the cuff of IVC. And then we place this in the recipient on the left side. So right kidney, generally, we tend to place on the left side. But in robotics, we can easily do it on the right side also. But in this instance, this is a second transplant. That's why we place the kidney on the left side. So you can see the ample amount of cuff obtained, and even the right kidney donors we can definitely perform in a robotic manner.
Vessels.
So here you can see the bench surgery.
Diabetic nephropathy
so
with atherosclerosis of the external iliac vessels.
Very bad vessel. You can see atherosclerosis
Once
of the
an
vessel.
arteriotomy was made,
just like in
the atherosclerotic plaques were fixed with inside-out stitches to prevent intimal dissection.
In open surgery that we do, we fix the plaque and then
This can be
subsequently anastomose it.
using a
So you can see the end-to-side anastomosis right here, and the plaques are fixed. So even the atherosclerotic arteries, they are not contraindications for robotic
and the
surgery.
clamps are released.
See here, you can see
In these vessels of
anterior layer.
care has to be taken that most of the bite should be taken inside out from vessels. With smaller,
This is one. So these are the complications of robotic surgery. See, once you get a bleeding, what will you do? So most often, if there's a bleeding, you apply a pressure on that, and mostly it will stop. If it doesn't, always you can take a suture. So massive bleeding is very rare after performing the robotic anastomosis under high magnification. So here, there is it is probably not stopping. The bleeding is more brisk. So I place a suture. So while doing the suture, the caveat is that you have to approach against the direction of the spurting. Otherwise, your camera will frequently get soiled, and that will create trouble for the assistant also. So another bite is taken. So you don't need to be really afraid about taking bites in robotic surgery. Even if it is in the anterior aspect, initially I used to have some trouble to tackle on the anterior aspect of the anastomosis, but still No, it is very much possible. So, and again, with a very good anastomosis, very unlikely to leak. Here you can see blood is splashed. So we have to clean up. And then again, suture. So it's all possible to, even the complications you can tackle with a robotic surgery. So, so far we have performed about 325 cases. Mostly it's live. We don't have cadaveric program now, so it ceased by 2017. And generally the patients stay in the hospital for about 6 days, 5 to 6 days. Blood loss is very minimal. Unless you have a massive leak, it's very minimal. The creatinine levels, generally they reach the nadir by about 72 to 96 hours. It's quite fast also. Once you gain experience, the bed preparation takes around 20 minutes, and opening of the abdomen and the gel point incision another 20 minutes. And the anastomotic time varies, generally from 25 to 38 minutes for single vessels, and for difficult, probably double vessels, it takes about 45, 46 minutes. Then you spend some time while graft positioning, and ureteric anastomosis, either way you do it, generally it is completed within 15 to 20 minutes, and another 10 minutes for flap fixation. So average time for the surgery, it's around 150 minutes once you are thorough with all the steps and your team is also tuned to that. And we have a large number of double vessels in our experience. Our double vessels are about 87 out of 325. The right side, as I said, initially I was a little bit reluctant to take the right side, but now I'm more and more I'm doing it. So we have only 20 cases. Then we have done 3 or 4 vaginal insertions. Pediatric cases, the least is 9 at what I have done, but about 13 to 14 cases we have performed in adolescent group. Retransplant is definitely possible. And the total extraperitoneal transplant, I performed 1 case in 2017, but now Dr. Anand Kumar and team has taken up this. They have performed already a dozen cases now, and they do with an XI robot. Since I don't have an XI, probably it is not feasible with SI robot as easily, but still with XI, they have demonstrated its feasibility. That is again another step ahead of the robotic transplant. And then Dr. Jihad Kahuk, he has performed single port extraperitoneal transplant. He has got a fair amount of series with a single port robot. Unfortunately, it is not available in India right now, but still that probably adds to the future. Our complications, we have 2 perioperative mortality. One had a sepsis in a cadaveric graft, and another patient died of a dengue fever, but no surgery-related mortality. And there was 2 arterial thrombosis. That is the first and 145th case. Of last about 175 cases, I haven't had any single conversions. And another 4 conversions due to vascular spasm, especially in the initial period. We had problems with vascular spasm with kidney in the steep pendulum position. But now we have supplanted with certain techniques so that vascular spasm is also very rare nowadays. The re-exploration, I had 2 cases early in my series. One was a surface bleeder and one patient had a coagulopathy, which was not detected pre-operatively. Both patients were salvaged with no delayed graft function. So this is pediatric transplants and an adolescent, a 13-year-old girl. The cosmosis is quite good with pediatric transplant. And these are some other rarities that we have performed. This is a patient with a thimble bladder who had a TB, and the bladder was removed. And here what we did was we identified the bowel segment and then we brought it outside. And then we did the ileoileal anastomosis outside. And we also made a opening in the ileal conduit for the ureteric anastomosis. And we pushed the bowel back inside. and then we went ahead with the transplant, the arterial anastomosis. And once the transplant was done, intracorporeally, the anastomosis was done with the transplant ureter. And a stent is being placed. So we had about 4 cases like this where a transplant was done into ileal conduit, all in a robotic manner. And once the anastomosis completed, conduit is extraperitonealized and brought out. So this is another pediatric transplant where we had multiple surgeries before. This is the smallest child by weight that we have done. There's a CAPD catheter also, which was removed. And other minor complications that we had, wound infection. Again, it's very rare nowadays. Wound dehiscence in one patient with everolimus and another diabetic patient. Ureteric leak early in the case, but both were done extracorporeally. Recurrent UTI, it still happens, especially in younger population. Delayed guard function in 2 patients who had arterial thrombosis. Lymphocyl, again, its rate has dramatically come down. In the first 220 cases, we had 5. Subsequently, we haven't encountered anything. Intestinal obstruction in 1 cases where there was a small rent in the flap and the bowel herniated through that. And 1 varus needle injury to actually the aorta, but a self-limiting hematoma. These were the complications. So this is our experience that we have published. Initial series, and then we publish with the grafts with multiple vessels, and then this is the one latest publication where we had an 8-year experience in the Gold Journal of Urology. So with the extraperitoneal flap and total extraperitonealization, I think we have taken care of all the safety concerns. I mean, injury to intraperitoneal organs is very rare. They're like and most of the complications can be dealt, as I've shown. And this is definitely advantages of early recovery, especially in obese patients. Post-transplant biopsy is really feasible. And bleeding into urinary leak and urinary leak into the peritoneal cavity, again, is very rare and does not happen at all with extraperitonealization. And you can see with very robust graft function, the effect of pneumoperitoneum is very negligible. So I think my final verdict will be, robotic transplant definitely has an advantage, significant advantage in obese patients, and especially obese patients and moderate BMI patients. In thin patients, the advantage is kind of reduced because of the intraperitoneal incursion. But with a total single port and total extraperitoneal, still it would have a role in thin patients also. Thank you.
Thank you, Dr. Kishore. I will ask a couple of questions and then we will conclude the session.
Sure.
Number 1, initially, if I remember, in early 2010-15 between, laparoscopically also this surgery was tried.
Yes.
And it failed most of the times and there was a lot of difficulties. After that, certain graft losses also have been reported and there was certain pause between this laparoscopic surgery and robotic recipient.
True.
So what are the initial hiccups you will face in this surgery? Like, for example, if somebody wants to start by seeing your surgery or by observing your surgery for 1 or 2 weeks, what do you think? What are the initial mistakes the surgeon do, even if he is experienced?
Yeah. First and foremost, I think you should have a fair amount of robotic experience under your belt. So at least should have 100 and 150 cases you should have performed on the robotic console. And then you should have, again, about a good amount of open transplant experience. So that will be a very good combination. And then, you watch somebody, you visit a center like where it is performed in a systematic manner. And subsequently, in first few cases, 1 or 2 cases, you can have a mentor. But most of the experienced surgeons I've seen, they go back and do without a mentor also. Those who have good experience with robotics and transplants. But ideally, if you're early in your career, you can have a mentor also for the first 2 cases. But then eventually, we can do it without much problem. And again, it is also important to convince your team, especially the nephrologist. So you should also ask the nephrologist to talk to the centers where the this is performed with good results, so that they will get convinced more. Especially younger nephrologists are more upbeat about these things, but it's very difficult to convince older nephrologists. So
Yeah. Because a lot of people say that creatinine nadir levels are slightly higher than the open surgery and worm ischemia time and the ice slash on the kidney are the concerns. So they say that better to avoid these type of technical issues will be there. And what is your opinion that you are getting good results like in other open surgery results?
Mine is almost, my time, in fact, has surpassed the open time. Very early, easy anastomosis I finished faster than open. And obese patients, definitely, it's much more convenient for me to perform robotically. So as you gain experience, I think robotics is such a wonderful tool. I think that will aid you to certain extent that you'll feel more comfortable than open, especially in high volume transplant surgeons. I think they will feel more comfortable with open. And as you say, no, you don't require eyes. I mean, I place eyes mostly for psychological satisfaction, I would say. But without eyes, Dr. Modi does not place eyes at all. And many open transplant surgeons, they don't like eyes. So ice is not required, but especially in the initial period, I think for your comfort, you can place ice. You can also reinforce also, but 50-55 minutes. I mean, does not produce delayed guard function. But again, no, another important caveat is that you have to really choose the patient. No, the robotic transplant is ideally indicated for obese patient, but that doesn't mean you should do it on an obese patient to start with. So you should start with a thin patient, easy patient, probably female patient, and then subsequently graduate to obese patients. Okay. So that's one error I also do. I also did. So initially I started taking on obese patients. Then always there will be a comparison, between obese and thin patients, and people tend to label that robotic transplant is inferior graft function, which is probably untrue. Beyond learning curve, it is as good as, or even sometimes even superior compared to open transplant.
Yeah. But I agree. It is inevitable, and it is. I'm able to see the number of papers that are coming, number of Indian urologists that are transforming into the robotic recipient. If multiple renal vessels are there, do you have experience making inferior epigastric artery anastomosis with one of the vessels?
Yes, I have done 3 cases. I'm not a big fan of inferior epigastric. So it is possible to do. The third one was a very large inferior epigastric, but the rest were like small. But it is possible to do. There is no problem. If you have, if you're doing off clamp, you can do it with a Prolene, because inferior epigastric is a very tiny vessel. So you can use Prolene or a Vascofill instead of Cortex. That is only technical suggestions, I would say.
Yeah. So initially we have done. Now we are not doing. What is the limitation?
No, there is no limitation as such. Generally, I prefer a bench surgery, like end to side, and for all upper pole small vessels. If they are far apart, I will do a double anastomosis as I depicted before. And if they are close and equal size, I would do a trousering. So 30% like that, I would say 1/3, 1/3 each. Yeah.
As far as the kidney,
You're dropping off. Can you?
or you do? As far as the vaginal insertion of the kidney in female patients,
Yes.
do you still do it or no?
No, I don't do, because live I don't want to take a chance. Okay, because any infectious complications can have a black mark on this one. So I've done mostly on cadaveric, all the patients, especially except for one who had very obese abdomen with a very capacious vagina. In that patient, I've done live, but generally I don't prefer, because my worry is that whether the graft will get squeezed, while placing, especially females with a narrow pelvis, sometimes. Yeah, and can produce subcapsular hematoma. So that is what my worry. But Dr. Modi has done more than enough. I mean, he has large experience, so it is safe, probably safe.
Thank you for being with me. I'm not able to view video and I really appreciate the takes from thank you.
You're dropping off, Chandra Mohan. I could not hear you, Dr. Chandra Mohan. Can you repeat?
Thank you, Kishore, for
Sure,
giving
sure.
the webinar on ASU.
For sure. Thank you. Yeah.
Interconnection tool. So
Sure.
thank you very much.
Thank you. Thank you.
Thank you.